Good afternoon, and welcome to the Johns Hopkins 30-minute COVID-19 briefing, where we provide live insights from the experts who lead our work at the Johns Hopkins Coronavirus Resource Center. For the next half hour, we'll focus on what you need to know right now about the COVID-19 pandemic and public health responses. As a reminder, we offer these 30-minute briefings regularly on Fridays. I'm Dr. Lainie Rutkow, a professor at the Johns Hopkins Bloomberg School of Public Health, and I'm part of the leadership team for the Johns Hopkins Coronavirus Resource Center. We'll be providing answers in real time today, so please submit your questions in the box at the bottom of your screen. Today, I'm joined by two guests. First, Dr. Jennifer Nuzzo, who's a senior scholar at the Johns Hopkins Center for Health Security and an associate professor at the Johns Hopkins Bloomberg School of Public Health. Jennifer will give an update about trends we're seeing in the COVID-19 data. Then we'll hear from Dr. Bill Moss, who is executive director of the Johns Hopkins International Vaccine Access Center and a professor at the Johns Hopkins Bloomberg School of Public Health. Bill will give an update about COVID-19 vaccines. I'm now going to turn to each of our speakers for a brief overview. Jennifer, first to you. Since we were last together, the Omicron surge has dwindled, and we're starting to see COVID mitigation measures that are being halted or revised throughout the United States. Do you feel like we're changing too much too soon, or is this level of optimism appropriate?
Yeah, thanks, Lainie. I think dwindled is not quite the right word, but we are certainly seeing declines, sustained declines. With our national case totals falling rapidly and every state reporting declines now. So this week we're seeing about 36% fewer cases than we saw the previous week. That is a very much welcome trend. And the fact that this trend has continued for multiple weeks is also very much welcome. But I just want to put into context when we're talking about dwindling, sort of where we are now versus where we've been. And where we are now is that in the past week, the average daily case number was somewhere around 75,000 cases per day. That is a decline from the over 1 million cases that we saw at the height of the Omicron surge, and very much welcome that we are seeing now a smaller number, but it's still very much higher than what we saw earlier in 2021 in, kind of the June time period, June of 2021. Then, our lowest lows were, really about 11,000 cases per day. So 75,000 to 11,000, we still have a ways to go to get back to where we were June of 2021. And that's why I won't call it dwindling, but I will very much celebrate the sustained declines that we're seeing throughout the country. We are seeing declines in our other metrics too. Hospitalizations, I think a key one, and now finally deaths. Deaths have been high for quite some time, in part because deaths are really a lagging indicator, and we were seeing the results of those very, very high case surges earlier in the year. So it's good to see that the numbers are ticking down, but again, we still have a ways to go. Now, in terms of your question about whether it's too soon to relax measures versus not, I think we have to kind of unpack what measures we're talking about, what we're effectively relaxing or what we're potentially shifting strategies on. I'll just take perhaps the issue of masking because it's very much in the news, and it's going to be in the news again later today with reports surfacing that the CDC is planning to issue sort of new recommendations in how they are going to assess community risk in terms of recommending that people wear masks at certain levels of community risk. Now, previously, CDC had relied heavily on two metrics, new cases, and also test positivity. And they use that to create sort of a risk map. And if people lived in areas of high risk, they would recommend that they continue to wear a mask regardless of what the laws in those areas said. We know that many places, including places that have sustained very high levels of case transmission for months now, have not had mandates in place for masking or really much by way of any measures. CDC has recommended that individuals continue to wear masks in areas of high transmission. The news reports that are surfacing today suggest that they are going to sort of change how they view community risk. And although a number of news reports are describing it as they are relaxing guidance on masks. I think it's probably more appropriately described as they are looking to multiple data sets to gauge risk. And truthfully, I think at this stage of the pandemic, that makes a lot of sense. I think test positivity and case numbers just tell us different things now than they did 6 months ago, in part because of increased reliance on home testing, which is not going to be captured reliably by those numbers. And also given the fact that we are starting now to think about other respiratory pathogens. So looking at broader metrics like hospitalizations and trying to understand how stressed hospitals may be, I think is an important dimension for us to consider, particularly after we've just come out of a wave that really has sent fewer people on a percentage basis to the hospital than what we've seen with earlier forms of the virus. So, I think we have to be careful not to kind of summarize for the headlines incorrectly what's actually happening. I think what you're seeing is that a lot of places that have, maintained mandates much longer than other states are now finally starting to lift masking as a legal measure, as a mandatory measure. But that doesn't necessarily mean that people in those areas will cease wearing masks. And perhaps it is a more targeted way for people to, look at what their community risk is and think about whether continuing to wear masks is beneficial to them. I think it is likely that people will continue to wear masks as long as our infection levels are high, or at least the people who are still wearing them at this point. And that, even if we shift away from mask mandates, we can still focus on encouraging mask usage, particularly in the areas where it's most needed.
Great. Thank you so much, Jennifer. And before I turn to Bill, I want to remind those who are watching, please do submit questions for our experts in the box at the bottom of your screen. I'm keeping an eye on those questions as they come in. Bill, since we last spoke, there have been several key vaccine-related developments, including a lot of questions about the timeframe for a COVID vaccine for the youngest children, meaning those who are under 5. Can you talk us through what we know so far and also put it in a global context?
Sure, Lainie. Since we last spoke 2 weeks ago, you're exactly right. There have been some new developments, but there are also things that aren't changing very much. And so I'm going to start with that. And I'm thinking of the vaccine coverage, COVID-19 vaccine coverage here in the United States. Jennifer described the declining cases and hospitalizations, but we've really seen kind of flattening of the curve in terms of vaccine coverage. Now we have really high vaccine coverage in the older adults, in the 65 to 74-year-old age group. 95% have received 1 dose, 91% 2 doses. So that's really good. But when we drop down to say 5 and 11-year-olds, only a third have received 1 dose and just a quarter 2 doses. So we still, and the curves for all the age groups have really plateaued. Since we spoke 2 weeks ago, the percentage points have maybe gone up about 1% in some of these groups. So we're not seeing, a kind of a sustained increase in vaccinations. Even with booster doses, fewer than half of adults in the United States have received a booster dose. If you look at those who are fully vaccinated, it's around 70%. But again, we see large age group differentials, with 65% of those in that 65 to 74-year-old age group having received a booster dose, but only 21% in the 12 to 17-year-old age group. Now, there are a number of reasons for this. For some people, it's actually just not 5 months since they received their second dose, so they're not yet eligible, of those who are fully vaccinated. Others find it inconvenient. They can't take time off of work for booster doses. And others, are less concerned about getting COVID now, or they don't believe that the booster dose is really helpful because they've seen so many people get Omicron infections who've had a booster dose. Now, in terms of the young children, when we spoke two 2 weeks ago, on Friday, February 11th, I was announcing that the FDA Advisory Committee was to meet that following Tuesday to discuss an emergency use authorization for the Pfizer-BioNTech vaccine for children 6 months to 5 years of age. Right after we spoke here, the Pfizer withdrew that application, and now what's happening is that we are waiting until Pfizer has the full data on the phase 3 trial with 3 doses of the vaccine. So this is now a 3-dose series in these children younger than 5 years of age. And listeners will remember that what had happened was the early immunogenicity data showed that in the 2-year to 4-year age group, the antibody levels were lower than what they had hoped that they hoped would be when they compared them to 16 to 25-year-olds. So we now have to wait until April is the estimated timeline when Pfizer-BioNTech will have the full data on the phase 3 trial with 3 doses in this younger age group. Now, another thing that's happened this past week is on Tuesday, the CDC issued new vaccine guidance on the interval between doses, expanding the recommended time between the initial 2 vaccine doses to up to 8 weeks for people over the age of 12. They still recommend, the original intervals, which is 3 weeks for the Pfizer-BioNTech, 4 weeks for the Moderna vaccine for individuals older than 65 years of age, those who are immunocompromised, or those who, as they say, need rapid protection. But they have expanded this interval for people outside those special groups. This is interesting, and some of our listeners will remember that there was a lot of debate earlier on about what the appropriate interval was, and it's driven by a number of different factors. One is that early on, when there was a vaccine shortage, a number of experts argued that it was better to get a single dose into more people than 2 doses into fewer people, and so extending the interval. And a number of countries adopted that policy. Also, from an immunologic perspective, we know from other vaccines that when you expand that interval, you tend to get better immune responses. But one of the interesting things in the CDC's announcement was that they think that there's some evidence to suggest that expanding that interval out up to 8 weeks may reduce the risk of the myocarditis, pericarditis, that inflammation of the heart and the surrounding tissue, particularly in young men. The evidence isn't really strong for that, but on February 4th, or earlier this month, the CDC did present a summary of some observational studies suggesting that may be the case. Now, another development is that there have been a lot of discussion and in the news recently about a number of the some of the protein-based vaccines. Remember, there are 5 different types of vaccines. We've got our mRNA vaccines and our viral vectored vaccines, the adenovirus vectored vaccines that deliver the genetic recipe for the spike protein. We have attenuated viral vaccines. There aren't very many COVID-19 vaccines that are attenuated, but that's our standard measles, mumps, and rubella vaccine. There are killed vaccines, or a number of COVID-19 killed vaccines not used here in the United States, but used around the world. And then lastly, these kind of protein or subunit-based vaccines where you just kind of inject the spike protein or part of the spike protein. So some things in the news, the Sanofi GSK protein-based vaccine, it's unpublished data yet, but the company announced pretty good efficacy data with that, 100% efficacy against severe disease, but down to 75% for moderate to severe disease. We know that Novavax last month applied to the FDA for emergency use authorization. That too is a protein-based vaccine, a little different delivery system. Those are called nanoparticles, very small particles injected. There's been in the news the Corbavax vaccine developed by Texas Children's and Baylor College of Medicine that uses another kind of technology to develop these protein-based vaccines. Number of Cuban vaccines, really interesting vaccines. And then just announced today that Medicago's plant-based COVID-19 COVID-19 vaccine was approved by Health Canada. This would be the first plant-based vaccine. So there are a number of ways to kind of make these proteins, and this would be the first in a plant-based vaccine. And then lastly, in the global picture, Lainie, we're still seeing gross global inequities. As we talked last time, I really expect the supply bottleneck to ease up this coming year, particularly as we see more vaccines come online, like these protein-based vaccines. And there are a lot of initiatives now to really transfer some of the manufacturing capacity and intellectual property and technical capacity to low and middle income countries so that they can manufacture their own vaccines. But if I can get the 4Ds in again, Lainie, the 4Ds that are kind of indicators of a successful vaccine rollout: doses, delivery, demand, and data. I think we're going to see the dose problem, that supply problem ease, but countries are still struggling with getting those vaccines into the arms, still facing demand problems and vaccine hesitancy. WHO just announced earlier this week that they're changing the way they provide vaccines through COVAX to many countries. Instead of just sending out what they have and countries not really being able to handle that, countries will be able to make more specific requests and know exactly what they're getting and when.
Thanks, Bill. It wouldn't be a Friday afternoon if we didn't have the 4Ds with us. I do see a lot of questions have been coming in, so we're going to turn now to Q&A. And Jennifer, I'm going to start with you. Questions about what else is out there. So now we're starting to hear chatter about BA2. Can you speak to that, or just more general concerns about what might be on the horizon?
Yeah, so I think that the takeaway is that there could be something else on the horizon. I haven't yet seen any particular variant or subvariant, which is what BA2 is, a subvariant of the Omicron variant. There's been some push to possibly reclassify it as its own variant, but nonetheless, I haven't seen any data that has made me worried that it's going to fundamentally change the game. There is some possibility that BA2 might have even more transmissibility than BA1, the Omicron variant. But so far suggests that it has similar levels of protection against vaccine to the Omicron variant in places where there have been a rise in BA2. It's kind of come and gone. It hasn't gone on to cause change the curves that countries have seen, but it's something that we're keeping an eye on. I think. But the general, I think advice is that there could be something else. And I think, to the earlier conversation about whether it's too soon to relax measures, I think we can acknowledge that we are in a different state now than we were a month ago. I think we can look to which measures may be amenable to relaxing, perhaps, no longer mandating, but encouraging. But that doesn't mean that there won't be changes in the future. This is a dynamic situation. We have to gather the best data that we can, and we have to be ready for changes. And if that means that something comes about that we didn't see before, we may have to respond, and that may mean putting back on measures that we have gotten a break from. I think that's just inevitable. But I think one of the other lessons that I hope we learn is that not all countries are looking for these variants equally. And in the future, if we find one, we should not rush to penalize countries that do report these. I worry that our response to Omicron, to penalize South Africa, that was particularly on the edge scientifically in terms of finding it, identifying it, characterizing it, and sharing those data with the world, suffered from travel restrictions that were put into place upon sharing those data. I know that has had a chilling effect on surveillance in other places. And so I think we have to just be open-minded that these things are going to happen, and we will have to respond and not necessarily sort of blame a country for finding it in the first place as though that country is the one that gave rise to it.
Thanks, Jennifer. I'm going to stay with you because we have a lot of questions coming in about masking. So since we were last together, we now have folks that are living or about to be living in jurisdictions that have dropped their mask mandates. What is your best advice? And again, I'm putting a lot of questions together around this theme. What is your best advice for folks that have been used to masking all this time and are now being told that it's optional?
Yeah, I mean, first of all, you make the decision that's right for you, and think about the other people who are around you. I still wear a mask. It's not required where I live. I still wear it when I go to indoor spaces, in part because the case numbers are high, in part because I, want to kind of signal etiquette for others that I may be around that may be much more vulnerable to the virus than I am. I look forward to the day when that's no longer necessary. But right now, I personally feel it's better to wear a mask, even though I am no longer legally required to. I have to say, I still see a lot of people wearing masks, despite the fact that isn't required. If you are somebody, though, who is particularly at risk because of some health condition, immunocompromised or something, I mean, wearing masks is still very much advisable, and high quality masks do confer a good amount of protection to people. So I know people are worried that now they're completely unprotected now that others around them may no longer be wearing masks. But one-way masking still does provide protection. So I wanted to kind of maybe assuage some worries there. I will say, though, that the places in the country that I am most worried about are the places in the country where vaccination coverage is lowest and where there have been no measures in place for months and months. So really what we're talking about in terms of lifting mask mandates are largely the states where there's higher than average vaccine coverage and the case numbers have fallen quite considerably. And so, I think those places are more amenable to lifting of mask mandates. They're not the top of my worry list. And so I think we have to just kind of put those recent measures in context. I know it feels jarring for people to think that they have been, possibly wearing masks, mandated to wear it for years, and now to suddenly see some faces uncovered. But I do think the places where that is an active conversation are actually in much better circumstances than the places that I have long worried about.
Thanks, Jennifer. Bill, several follow-up questions for you from things that you mentioned in your opening remarks. Can you say a bit more about what's going on with WHO and this tech transfer change that we've been hearing about?
Yeah, so I mean, WHO is it has a number of different initiatives to try to increase vaccine manufacturing in low and middle income countries, and I think it's a really important initiative to do so. We cannot allow certain parts of the world to be so dependent on foreign made vaccines, such that they cannot vaccinate their populations. So there are a number of different things they're doing. One thing that's been noted recently is they're setting up in South Korea a training facility so that people can learn the technology. And I think this is really important because we've talked before, Lainie, I think, about just transferring just the intellectual property is not sufficient. People need to know how to basically take that recipe and make high quality, consistently high quality complex biological products. So I think that's a very important first step toward improving the manufacturing capacity around the world.
Thanks. And Bill, another follow-up for you. So you teased us with the Canadian plant-based vaccine. Can you say a bit more about that, please?
Yeah, so it's actually, just like with the mRNA vaccines and the adenovirus vaccines, although they're new vaccines, the science behind it has been in the works for decades, actually. So this basically what you want to do with a protein-based vaccine is find some way to manufacture that protein. And you can use bacteria, you can use yeast cells, you can use animal cells, all grown, and basically you get those cells to manufacture the protein. But in this case, it's using a plant. And again, there's a long history of kind of research in this area of using plants to manufacture proteins. But this would be the first plant-based vaccine to actually be used in humans.
Something tells me that we'll be talking about that one more in future briefings. Okay, Jennifer, a topic that came up for the first time on our last Friday briefing. I predicted it would come up again, and here we are. Can you speak to the term endemic and what it means in the context of COVID, or what it may one day mean in the context of COVID.
Yeah, so it's interesting that people say, when will the pandemic end? When will it be endemic? And they're sort of mixed terms. Pandemic really describes sort of a geographic spread, whereas endemic is really about sort of the expected frequency and whether that frequency sort of sustains itself without some kind of external input, like infected travelers coming into a country to keep case numbers at that frequency. I think what people are talking about now is reflective of the fact that we acknowledge that this virus, the SARS-CoV-2 virus that causes COVID-19, is not going to disappear. So it is going to be with us, and we are going to continue to see it. We are going to continue to encounter it in our lives. Really important reason why you should get vaccinated. It's not going to be possible to kind of sit this one out. It's not yet endemic. We're still at, very high levels of case numbers. The numbers are falling. We don't yet know what the endemic level of infections will be, what that sort of expected frequency of infections. We don't fully know if it's going to fall into a seasonal pattern, though I think there's increasing belief that it will. We don't know what that season will look like and when it will start and when it will end, and then what typically we see in terms of case numbers for that season. So we're not there, but we are having a conversation about, given the fact that this virus isn't going to go away, given that the fact that we're never going to drive case numbers down to zero, what should our strategy be in responding to it? We have great vaccines to keep people out of the hospital and to keep them from dying. So given that, should our goal be trying to completely stop transmission or to drive transmission down to minimal levels? And what are the kind of trade-offs with those approaches? And so that's really where the conversation is. But, I think the fascination of endemicity sort of misses the mark, which is that we are still at high levels of infections. That is something that we have to continue to be concerned about and to think about how to make sure we protect ourselves from it.
Thanks, Jennifer. And with that, you get the last word today.
No,
you don't. No, you don't. Bill, go ahead.
I have to put a proposal on the table. The pandemic ends when we stop doing these Friday briefings.
What are we going to do with our Fridays, Bill? We'll share recipes.
No comment. Okay. I'd like to thank Jennifer Nuzzo and Bill Moss for joining me today. Give a big thank you to everyone who joined us, and especially those who submitted questions for our experts to answer. As always, this briefing will be archived and available on coronavirus.jhu.edu. As a reminder, we will continue to offer these 30-minute briefings regularly on Fridays this year. Our next briefing will be on Friday, March 11th at 12 p.m. I look forward to seeing you next month. And until then, thanks and stay safe.